Okay, I'd like to welcome everyone. I think we'll have people joining in the next few minutes, but our protocol is to start at 5 past the hour. So we will start now. My name is Dr. Kathleen Crivero. I'm a distinguished lecturer at the CUNY Graduate School of Public Health and Health Policy. And this is one in the series of the Dean's Grand Rounds. And we have our Dean with us, Ayman El-Mohandas, and I just want to thank him for his leadership for this lecture series. And once a semester, the Center for Immigrant, Refugee and Global Health organizes a number of webinars during the semester, but one of them is part of the Dean's Grand Rounds. And we always try to highlight a relevant global health issue when it's our turn to organize the Grand Round series. So today we have asked representatives of the Elizabeth Glaser Pediatric AIDS Foundation to talk to us on the subject of ending pediatric AIDS in the shadow of COVID-19, the journey thus far and the road ahead. I just want to say a couple of words. First about the Elizabeth Glaser Pediatric AIDS Foundation, and then a little bit about our panelists and how the lecture or how the webinar will proceed today. First, the Elizabeth Glaser Pediatric AIDS Foundation. Not everyone on the Zoom might know about how this foundation came to be, who Elizabeth Glaser was. Elizabeth Glaser was the wife of an American actor called Paul Glaser, and she contracted HIV in 1981 through a blood transfusion. She was unaware that she had contracted HIV. She actually passed it to her daughter through breast milk, her daughter Ariel, and to her son Jake in utero. Ariel, when her parents, Elizabeth and Paul, were trying to get support and treatment for their daughter Ariel, they realized there was very little available and very little known about pediatric AIDS. So Elizabeth started the Pediatric AIDS Foundation as a way of ensuring that HIV/AIDS in children would get adequate attention, both in terms of prevention, treatment, and care. Ariel actually lost her battle with HIV/AIDS in 1988. Her brother Jake is alive today and active in some of the activities of the foundation. And Elizabeth herself passed away from AIDS in 1994. One real spotlight moment for Elizabeth Glaser was she was the main speaker at the Democratic National Convention in 1992 and really put a whole different face on HIV/AIDS. Before that, it was a disease of gay people, or it was a disease that was far away, but Elizabeth Glaser, for the American people, really brought home the fact that HIV/AIDS need to be looked at as a concern for everyone. And it really made a huge difference in the course of what happened with AIDS in the United States. After Elizabeth died, the Pediatric AIDS Foundation was renamed the Elizabeth Glaser Pediatric AIDS Foundation, and the foundation has transitioned from being primarily domestic to primarily global. And you'll hear about that some today. I've had the great privilege of being a board member of the Elizabeth Glaser Pediatric AIDS Foundation for almost 10 years. And it has been truly impressive to see how it has grown to be an organization of over $200 million a year, working over time in well over 30 countries and in most of the countries in sub-Saharan Africa. So we have the way that the lecture will work today is we will have the 3 presentations. During those presentations, Ansley Hobbs, who you can see here on the screen, she will be moderating the chat and making sure that we're catching all the questions as they arise. So while we won't take questions after every speaker, please be entering your questions into the chat as they occur to you, and we will take them up at the end of the 3 presentations. So with that, I'd like to introduce our three speakers. First, we have Anja Giphart, who's the Vice President of the Elizabeth Glaser Pediatric AIDS Foundation and is responsible for providing technical leadership and direction for the long-term strategic vision of the foundation's implementation of its strategy and its research initiatives. Anja's been with the organization since 2004. We also have Apollo Tiam. He's calling in from Cameroon. So Apollo has said he's had a few connection problems, but we hope that it will hold for the webinar. Apollo is Vice President of Technical Strategies and Innovation, and he oversees implementation of the technical leadership, innovation, and new technology initiatives within the foundation. And our third speaker is Judith Kose. She's calling in from Kenya. She is the Associate Director of Pediatric Services for the foundation, and she provides strategic direction for improving pediatric AIDS services, including TB and for other comorbidities. So it's with great pleasure that I now turn to Anja to begin her presentation. Thank you.
Thank you, Kathleen, and you made my life much easier by talking already about the Elizabeth Glaser Pediatric AIDS Foundation and introducing my colleagues. So I don't have to do that anymore. So let me start with saying thank you. Thank you for organizing this lecture. Thank you to the Dean, Ayman El-Mohandes, for inviting us, and also thank you to the directors of the Center for Immigrant, Refugee and Global Health at CUNY. We're delighted to be here and to share our experiences and our journey in ending HIV and AIDS in children. I'll share my screen. Oh, my apologies. Let me. Is this, can you see this, Kathleen? Okay. So again, thank you for inviting us, and thank you for those who are attending us, and good morning, good afternoon, or good evening, depending on where you're dialing in from. What we are going to talk about today is where we were in terms of the pediatric HIV epidemic before COVID, what impact COVID has had on our work and the general situation around children with HIV, and what we believe must be done and can be done urgently to come closer to our mission of ending AIDS in children. So the estimation of UNAIDS is that there are 1.7 million children living with HIV globally today. You can see from this slide that the majority of the children are in the South. Close to 70% of children and adolescents living with HIV are in Africa, and 75% of those are actually in Eastern and Southern Africa. You will see we go a little bit between talking about children age 0 to 14 and children, adolescents between 0 and 19. Unfortunately, it's not very standardized in our work, but you will see the differences between those numbers. Almost half of the children and adolescents living with HIV are not on life-saving treatment today, and that number you will see later is actually declining. We also need to mention that 1/3 of the children who are born to mothers living with HIV are not being tested for HIV. And that's really important, because if a child is not identified and subsequently put on treatment, 50% of the children will die before the age of 2, and actually 80% of the children will die before the age of 5. So it's very different from adults. We need to be very fast in identifying these children and putting them on the appropriate treatment. So what is the journey so far in relation to new infections? Here you can see that in 2000, we had roughly 500,000 children annually newly infected of HIV. And the good news is that it's down to 150,000 a year. There was a great decline between 2004 and 2012, and this was mainly because of the scale up of prevention of mother-to-child transmission services, meaning that pregnant women were being identified living with HIV and put on the appropriate treatment for their own health as well as for the prevention of transmission. So it was the services that were scaled up. It was also the regimens that mothers were receiving that really helped that significant decline. Unfortunately, we see that the decline now is getting much slower. And in the last year, only 10,000 children were added to the number of children. The reduction was only 10,000 in terms of new children being infected. And what you can also see on this slide is that the targets that were set under an initiative called Start Free, Stay Free, AIDS Free, where the target for 2080 was 40,000 children being newly infected per year. And in 2020, actually 20,000 children newly infected in that year. We are grossly missing that target. And what's even more disturbing is that if we continue with the current decline rate, it will take us more than 13 years to get there. So a lot of work needs to be done, and Judith will talk about that more. So what are the causes of new infections in children? And we divide that into two time frames. One is that the child gets infected during pregnancy and labor and delivery, which is of course a very short moment. And then the child being infected during breastfeeding. And you can see here in this graph that there are different contributions at different times. So for the infection during pregnancy, the biggest contribution is when the mother did not receive antiretroviral therapy. So either she was not identified as HIV infected, or she was identified and for some reason did not receive antiretroviral treatment. For the infection during breastfeeding, there's two areas that stand out. One is that the mother got newly infected during the pregnancy or the breastfeeding, or that the mother dropped off her antiretroviral treatment and therefore her viral load increased. So there are basically three major gaps that cause the mother-to-child transmission. And you can see here that in 27% overall, there was the lack of maternal antiretroviral treatment during pregnancy or during breastfeeding. And 27% of the new infections, it was caused by an acute infection during pregnancy or breastfeeding. And we all know that during an acute infection, the viral load is significantly higher and therefore increases the chance of transmission. And then finally, 24% of the new infections are related to the mother being lost in the care system and no longer taking her medication. So as mentioned before, at the moment, we are estimating that about 150,000 children are getting newly infected this year, which is a fourfold of the target. So where do these children live? And under the global plan towards the elimination of new HIV infections among children and keeping their mothers alive, there were 21 focus countries targeted because there the most infections occurred. And you see that those countries still continue to be the main focus of our work. Nigeria contributes 90% of all the new infections annually. Mozambique and South Africa, each of them 11%, and you can see the other percentages going there. But basically, it's 9 countries that account for 80% of the new infections, and therefore really the countries where we need to focus on to turn the tide. On the right side, you can see the mother-to-child transmission rates per country, and you will see that even though South Africa contributes 11% of the new infections, they're actually doing pretty good in terms of reducing the mother-to-child transmission down to 4%, but just the volume of people living with HIV still makes that they are a big contributor. There are other countries, obviously, on the top, like DRC, Nigeria, where we still have a lot of work to do and where the transmission is still very high. The green part covers the transmission estimated during pregnancy, and the orange bar is at the end of the breastfeeding. So every child theoretically should be receiving an early infant diagnosis test before the first 6 weeks, again, related to the very fast progression in illness in children who are infected. So the first test should be done by 6 weeks, and then the last test should be done by the end of breastfeeding, where the risk of transmission ends. But you can see there is quite a big difference between countries and where they are in scaling up their services. Talk a little bit about the number of children on ART. Again, the good news is that it has doubled since 2010. But again, all the targets have been missed. It's also important to note that the treatment coverage in children in 2019 was significantly lower, namely 53%, compared that it was for adults at a global level, which was at 68%. The target for 2018 was that out of the 1.7 children, 1.6 should have been on treatment, but obviously we missed that. 2020, 1.4 million, and you might wonder why there is a decline in the number of children we want to have on treatment, but that's because the number of children globally are reducing living with HIV. The transmission has slowly been declined, as we can see. And of course, what is interesting with children, they age out at some point. So at some point they are becoming older, which is good news, and therefore they age out on that cohort. And that's why we see the targets being lower in 2020 than they are in 2018. Unfortunately, though, we do see a significant plateauing of the number of children on treatment. And again, Judith will talk more about what we believe we need to do to really change this. As we said before, children are 40% less likely than adults to be on treatment. And if we look at the children between 0 and 14, who are the ones who are still not receiving treatment? And you can see here that about 1/3 of the children are age 0 to 4, a bit over 20% are age 5 to 9, and then 41% are children age 10 to 14. And it's important to know that because the activities and the strategies that we use to reach those children will be very different. The young children we will find in the MNCH clinics, but the older children will have to find either in the OPD or in the inpatient clinics, or obviously in the community, that you will hear more about that. And then my last slide is just making also another observation that really the AIDS related deaths disproportionately are in this age group again, because children make up only 5% of all people living with HIV, while they account for 15% of all the death-related, AIDS-related deaths. So again, we see here that there is a lot of progress made, especially in the green line for the younger children, but still a lot of work to be done. So let me here hand over to Apollo, who talks more about what COVID-19 has done in our fight against pediatric HIV. So Apollo, take it over from here.
Thank you very much, Anja, and thanks everyone, and thank the organizers for the opportunity. We all know that COVID-19 changed the world, and we have learned quite a number of words such as face mask usage. If you don't use face mask, it's a little bit odd, you know, and we know all the different schools of thought around face mask. We also know virtual working from home, and sometimes even some of our friends, like our cats and our dogs, not getting tired of seeing us working for long hours, you know, on the computers and all that. Next slide. So we also realized that for pediatric HIV, certainly HIV and COVID-19 in children is what we call double trouble. You know, basically because COVID-19 has had huge impact on health care services, especially for HIV. But we also know that there are several aspects to the trouble. There's a direct effect of COVID-19 infection on children. We also have COVID-19 related disruption of maternal and child health services, and COVID related disruption of HIV services, all culminating to health and well-being of infants and children living with HIV, having you know, difficulties to access their treatment, and some of the results that Anja has shown, you know, being impacted. And obviously, the question arises that what? Anja, you move too quick. Okay, can you go back to the previous slide? Okay, that's fine. So some of the questions that arise is what parts of the cascade continuum are affected the most? Have countries been affected equally? Obviously not. Are pregnant women and children more affected by disruptions? Again, that's a question we need to ponder. And what are the mitigation strategies? And of course, what next? Next slide. So we all know that 4.2 million children, adolescents, pregnant, and breastfeeding women with HIV need continuous access to antiretroviral therapy. And as I mentioned initially by Anja, 89% on womb and sub-Saharan Africa. However, because of the challenge around COVID-19, we have 2.8 million children and adolescents with HIV that are experiencing severe adverse effects of the disease. Certainly, we can say coronavirus-related disruption are a major threat that may reverse the decade-long progress made for children and pregnant women in the fight against HIV. And in the words of a young adolescent on the continent who said she's living with HIV and I have been taking her ARV for 5 years now, and she's fit and healthy. So the question is, will this adolescent say the same thing a year down the line, or 2 years down the line, or 3 years down the line? Next slide, please. So the new infection in children have decreased by how we know that, and we've seen that. But COVID-19 certainly is reversing the gains. And the effect of COVID-19 related HIV is disruption on HIV outcome among children aged 0 to 14 can be seen in the diagram below, where we can see that depending on the duration of the disruption of the services, certain different percentage of the population is affected. And you can see the curve in blue is the base, and the graph in blue is the baseline. In case things were normal, you see that for the new infections, things will have remained flat. But with the disruption, the ongoing disruption, we can see the rising in the number of new infections among children 0 to 14. And on the right side, you see the disruption also impacting negatively on the number of deaths. When I say negatively, that means the number of deaths actually rising, as the disruption continues over time. The next slide, please. So, in this snapshot survey, we noted that the HIV testing fell by 41% in 2020. This is key because the HIV testing is the rate limiting step to define who is going to access treatment, who is going to be enrolled into care. So a drop of 41%, the implication is that there are several people out there who do not know their status, thereby they can present late in the disease and with the risk of dying, obviously. Next slide, please. So the impact of, continue to look at the impact of COVID-19, we look at certain interventions, in the public health sphere where we had talked repeatedly or design programs such as differentiated service, which is a kind of service focused on the client, community-based, which is the decentralization of services also outside the facility, and integrated or co-located services and embracing technology. All these things initially, where there was a kind of direct impact based on the COVID, and I want to talk about that a little bit more in the next slide, Anja, please. Next slide. So because of COVID-19, there was actually a need to bring services closer to the people to catalyze the differentiated service delivery model where people receive the medicine maybe for 3 to 6 months, and when they are clinically stable, and all the teams actually go to community to provide them with their medicines, or we use technologies to monitor some of the work that the progress in terms of health outcomes for the patient. So there has been that opportunity, during this season to move things forward. Next slide, please. So the additional impact on the service and accessibility, we know that almost 200 on other services, almost 200,000 additional stillbirths could occur in the next 12 months due to the impact of COVID. Basically, this is due to the fact that women are not able to go to the facility to receive the usual care. And from this model, we can see various scenarios based on the decline, within 3 months, 6 months, 12 months, some of the decline that will happen in terms of women accessing the care. If they don't access the care, some of the tragedy that may happen as the number of stillbirth rises. Next slide, please. So just summarizing all the overall impact based on the restrictions on travel, we all know that as global health community for almost 2 years now, or very soon it will be 2 years that we have not been able to travel. From the HIV perspective, national ARV supplies and the implementation of multi-month dispensing were also put at risk because of this, because basically, and in the US, we're experiencing that, the logistic and the supply chain that has affected the drugs, it has affected some of the basic needs in the US. In the HIV community, that certainly has affected, the supply chain of antiretrovirals across the world. And in mid-June 2020, Tanzania, taking the example of Tanzania, has several delays in shipment due to global chain disruption as a result of COVID. And also this disruption affected the training of the healthcare workers as we introduced new drugs for children, the pediatric formulation that was the formulation that were more efficacious and optimal for their care. The training were disrupted because we had to follow the restrictions that would limit the transmission of COVID. Next slide. That's my last. So other essential public health measures, we also know that due to COVID, 80 million of children under the age of 1 year in at least 68 countries may miss out their life-saving vaccines. And this time around, I'm not talking about COVID vaccines. I'm actually talking about measles vaccines and other vaccines of diseases that have been controlled over the years. Next slide. So over to you, Judith.
Thanks, Apollo, and greetings, everyone, from very rainy Nairobi. I want to thank the organizers for inviting me to speak to this audience. I will also request that you allow me to go off video during my presentation so that I can optimize my bandwidth. The sky is pregnant with rain and it's going to pour, and so I suspect internet may be unstable, but I'll be back on video once we start the Q&A session. So picking up from where Apollo left, I want to start with a quote from a legendary American poet, Maya Angelou, that states, "You can't really know where you're going until you know where you have been." Next slide, please. And so looking back at the current status, so Anja has spoken about the status of pediatric HIV before COVID. Apollo has emphasized the additional effect of COVID on pediatric HIV. And so looking back, the data is there, the data is speaking loudly, and it's telling us where we are. And in summary, what do we know from what has been discussed? So as Anja mentioned, pediatrics are still left behind on all fronts, be it identification. And remember, identification is key before we talk about putting people on treatment. Pediatrics are lagging behind in terms of linkage to treatment, access to life-saving ARVs, achieving and maintaining viral load suppression. We have mentioned the continued disparities in HIV treatment coverage among children as compared to adults. Retention in care is an issue, and indeed, COVID has affected that. And also, Apollo has highlighted some of the risk of reducing the gains because of COVID, and hence the need to improve service delivery and adopt newer methods. And so based on this, we are going to be discussing some of what we believe are the game changers. And I want to start with this slide, presenting what we think are areas where we need to focus on to improve pediatric HIV services towards ending pediatric AIDS. And I will speak more on some of these areas in subsequent slides. But basically, the game changers would be one, focusing on HIV case finding, different approaches, different methods, including point of care, early infant diagnosis, index testing or family testing, and also targeted provider-initiated testing, optimizing treatment for children so that they get the best treatment at the right time, improving retention strategies, and Apollo mentioned multi-month dispensation, and this really is not common with children. A multi-month dispensation is where you give children ARVs for more than 1 month so that they don't have to come back to clinic. Improving defaulter tracing services and psychosocial support. Some of the game changers include improving the coverage of viral load testing and aiming at improving the viral load suppression, adopting differentiated models of care. So apart from what we already mentioned, the multi-month dispensation, adopting case management, caregiver support, and also addressing unstable clients. And unstable clients here would be those who are adhering poor to care or with high viral load. Community engagement is key for demand creation, for creating partnerships, and improving service delivery. I'll mention briefly about the fourth 90, to ensure that the child is reaching their full potential so that children who are HIV exposed, maybe not infected, but just exposed, as well as those who are infected, have a chance at life and our well-being, and indeed adopting lessons from COVID-19 as well to improve on the services for the children. Next slide, please. And so the best place to start is eliminating mother-to-child transmission. And I think Anja already highlighted on some of the gaps. And there should be efforts placed in areas that contribute more to transmission. So based on the stack analysis that Anja shared, the key areas where we should focus, where we have gaps, include improving maternal ART, addressing acute infection during breastfeeding. And just to tell the audience that in Africa, where most of our work is, mothers breastfeed for as long as 18 months and 2 years. And so breastfeeding is a major factor in terms of mother-to-child transmission, and also ensuring that mothers are retained on their treatment. And so the key interventions would be for each region to do their own stack analysis to identify where we need to have these interventions, to have prevention services so that we prevent acute infection during breastfeeding by scaling up PrEP as well as self-testing, support retention in care and on treatment for pregnant and breastfeeding women to ensure once they are started on treatment, they stay on treatment, they are virally suppressed and reduce transmitting to their children. And this can be done through peer support, introduction of long-acting treatment, integrating services, as well as differentiated service delivery. And the long-acting treatment, I know is being used in the US, but this is yet to reach Africa. There's a lot of research, a lot of work that is ongoing. And so this will go a long way in terms of preventing new infections, as well as for the ones who are on treatment, optimizing treatment for them to ensure they stay on treatment, they are virally suppressed, and they maintain viral suppression. Next slide, please. So apart from addressing the prevention of vertical transmission, a key element to address is the gaps around early infant diagnosis. And this early infant diagnosis, or what we are calling commonly EID, is really testing as early as 6 to 8 weeks to ensure that children or infants who are infected either during pregnancy, breastfeeding, or delivery are identified early and put on life-saving treatment. So some of the strategies to improve early infant diagnosis include scaling up the point of care EID testing, where the testing is done at point of service and they receive results quickly and put on treatment, accompanied by policy change so that this testing is done in areas beyond PMTCT, but also addressing some of the issues that prevent uptake of early infant testing. And for example, in our countries in West and Central Africa, elimination of user fees would be key in order to improve the uptake of early infant testing, to identify these children, put them on treatment early, and avoid death. Next slide, please. And still on HIV case finding, so apart from early infant diagnosis, there needs to be targeted testing. So remember, the early infant diagnosis is really for children who are less than 1 year. And if you look at this graph on the left, it shows the age distribution of children living with HIV. And Anja already mentioned why the percentages have changed. So from 2010, we had 39% of children 0 to 4, and now we have 26%. So not only is it because of improved PMTCT methods, but also children aging out. And so when you're doing targeted testing, we target based on where the population is. So for the 0 to 4, we would improve early infant diagnosis, but also scale up targeted provider-initiated testing and testing at delivery points where they're receiving care. For the children who are 5 to 9, these are school-going children, and for them, we would need to scale up pediatric index testing. So really targeted testing to identify the children that are diagnosed once you know who they are and where they are. Next slide, please. So once they're identified, another area to focus on as a game changer is to optimize pediatric testing. And from our programs at EGPAF, we know a couple of actions that are essential to support pediatric treatment optimization. So this includes supporting countries to improve their policy and guidelines to ensure that they are able to offer the best available treatment, advocate for sustainable funding to ensure that the pediatric ARVs are available in countries around time. The other area is to support procurement and supply chain. So not only supporting the quantification and supply of approved formulations, but also addressing the issues of suboptimal legacy formulations so that children are on optimal treatment. There's need to support material development, not just for clinicians who offer the services, but caregivers as well as improving service delivery and particularly pharmacovigilance so that we can monitor acceptability, tolerability, and adverse reactions as children are put on treatment. Next slide, please. So apart from treatment optimization, the slide hasn't moved yet. Or maybe it is slow on my side.
Sorry, I don't know why it's suddenly not moving.
That's technology. You can give it a minute and see if it moves.
Okay.
And maybe you can.
Anja, just click on the slide and press forward.
Yeah. Okay. Thank you. That was the trick. Click on the slide.
Thanks. That was a virtual health break. So the other strategy to focus on is strategies around improving viral load suppression. And as you can see on the graph on the left, if you compare viral load suppression among adults, it's at 91%, and yet for children is at 75%. And this is for those who are on ART on treatment. But if you take all children living with HIV, viral load suppression would be lower at 40%. And so this is also the disparity or the disproportionate, services that Anja mentioned. So there's a need to scale up services to improve pediatric viral load suppression. At Elizabeth Glaser, we have a viral load suppression toolkit. So the interventions include, apart from optimization and case management, the need to scale up the use of viral load results to improve services and to create action once the viral load results is released, capacity building for utilization of these results, and also strengthening of cohort monitoring, as well as strengthening the collaboration with community partners for psychosocial support at community level. So really scaling up evidence-based interventions to improve viral load suppression. Next slide, please. So talking of community, we can't really talk about improving pediatric services, ending pediatric AIDS without the role of community partners. So the OVC there is orphans and vulnerable children. In the development world, we are known for a lot of short forms. So the OVC is orphans and vulnerable children, and the CSOs is civil society organizations. So when you talk about pediatric services and ending pediatric AIDS, there is a complementary role for OVC programs. CSOs, civil society, thank you, and civil society organizations have a key role in community-led monitoring. These two teams have a joint role in terms of demand creation and advocacy. So this is a key tool that we use, and even at Elizabeth Glaser Foundation, we have an advocacy team, and we work with the community partners to ensure we are addressing the gaps and also championing for interventions to be scaled up across the different countries. Next slide, please. And so as we talk about children and ending pediatric AIDS, there is also need to address the needs of children who are HIV exposed and not infected, as well as those who are infected, to increase their quality of life. And so WHO has released the figure you see on the left, and this is aimed at addressing the health and well-being of children exposed to and infected with HIV. So not only does it require the screening of comorbidities such as cardiac diseases, lung and renal diseases, but scaling up other interventions such as nutrition, nurturing care, managing psychosocial status and mental health, as well as referring them for other services as required. So children are considered a vulnerable population. They face a lot of challenges, and so the services needs to be incorporated within the pediatric HIV services to ensure that children are not only enrolled in the OVC programs, the Orphans and Vulnerable Children programs for critical services, but also begin focusing on the pediatric non-communicable diseases, because studies have found that without focusing on these NCDs, then we are likely to lose the gains that we are having as we support the children. And there's need to then integrate these services within our traditional pediatric HIV programming. Next slide, please. And so as Anja said, really, we can't talk about anything in this day and age without mentioning COVID. And Apollo highlighted some of the effects that COVID has had in pediatric HIV services. And so one of the interventions that we are championing for is to ensure we continue with the mitigating the effects of COVID-19 and harnessing lessons. And we know that the new HIV infections among young children have decreased in the last decade, but those gains could be reversed because of COVID, like Apollo mentioned. COVID-19 control measures that result in reduction in access could mean fewer children are accessing the facilities, fewer of them are able to receive the child saving treatment. So as we address some of these losses that we anticipate that may happen, we also need to harness lessons and adopt some of the newer methods of doing work that COVID has brought. One of them is, in the virtual space. So right now I'm in Nairobi and I'm speaking to people in New York. So we are in a virtual space and we are able to communicate and interact. So in terms of pediatric services, we've adopted pediatric case management virtually. We have virtual adherence counseling, and this basically means the adherence counselors are given a script that is approved to follow as they give counseling to ensure that quality counseling is received. We are supporting a lot of our adolescents and caregivers using the WhatsApp support groups. So it's a closed group, and they enter they are approved to be added to the WhatsApp group, and you're able to communicate, as well as remote facility support through the cell phone and WhatsApp. And indeed, the modification of services such as the multi-month dispensation with stock management. And just to emphasize that multi-month dispensation has been there before COVID for adults, but during COVID, there was a rapid uptake of multi-month dispensation for younger children. And so indeed, efforts around staying with this multi-month dispensation, being resilient and adapting this within COVID, as well as integration. One of the things we have done at Elizabeth Glaser is to integrate our TB and COVID integration tools, as well as the dashboard, so that even as facilities screen for COVID, they're able to screen for TB, including those who are TB HIV co-infected, to be able to be managed. Next slide, please. And so this is our acknowledgement slide. And I don't know if Anja, you want to take this, but really we want to thank all the ones on this slide, including our EGPAF teams who have contributed to developing this slide deck. Thank you very much.
Thank you very much. I think we can stop sharing. Great. And hopefully we'll have our three speakers visible now as we move into questions. And as we're organizing the chat, we have some questions, but I think it would be important to clarify one point for Anja and colleagues. We've talked about, there's been several references to ending pediatric AIDS, and then a lot of attention to the treatment and maybe the disruptions in treatment that children have suffered as a result of COVID. Could you just speak, could someone speak just for a couple of minutes to the whole idea of ending pediatric AIDS? Because we hardly ever come across a problem in global health where you can talk about ending it. So I just wondered, for everyone, if you could explain how actually, even before COVID, how close within reach was that amazing idea that you could actually end pediatric AIDS?
Thanks, Kathleen. I can take a start and then my colleagues can add to that. But I think we really believe that we can end AIDS in children because we do actually have all the tools to do so. We can bring the transmission rate down to, as we've seen even in some of our African countries, but also in the United States, to less than 1% transmission rate if we use all the tools that we have available. And for those children who unfortunately still either already got infected or will get infected, there are very good treatment options these days to make sure that they can live healthy and productive lives. So they might be HIV infected, but they should not progress towards AIDS. So we believe we have all the tools to do so. The challenges in implementing those tools appropriately and consistently across the board and making sure that there are appropriate strategies in the different countries. What we need to do in the US might be very different from what we need to do in sub-Saharan Africa, from what we need to do in Asia. And I think that the population that we're trying to focus on is also different. In the United States, it might be more mothers who fall through the cracks of the system especially mothers using drugs or other reasons, maybe immigrants, why they are not following the normal available services. Well, for many people in the lower income countries, the services are not even available. So I think making sure that we use the tools that we have everywhere in an appropriate way, we really believe that we can indeed end AIDS in children.
Okay, great. Thank you.
Yeah, if I could just add a bit more. Thanks, Anja. I think I agree with you, Anja. And just to add on to what you said, when we talk about ending pediatric AIDS, I see it in two ways. So the major one is stopping the new HIV infections, and 90% of pediatric infections come from mother-to-child transmission. So a lot of that work would be around eliminating mother-to-child transmission, which, like Anja mentioned, some of the prongs is in 4 prongs. So this means preventing primary infection. So, you have prevention methods and talking to young women for and preventing pregnancy. For the ones who have HIV, you prevent them from getting pregnant if they don't want to, so that they don't transmit the HIV. For the ones who fall pregnant and have HIV, there's a lot of medication to prevent transmission. And for the ones whose children get HIV, then we manage them to avoid death. So really, there's a lot that's happening, and it is feasible. So science has shown that it's possible, and this is the effort around where the foundation is working.
Okay, thank you. I'd like to, there's a question about what EGPAF knows or is engaged in related to programs or studies that are following up children who age out. In other words, they're getting special attention perhaps as children, and then they age out as children. I mean, is there follow-up of these kids as they grow older? I don't know. So
maybe I could start with that, and Apollo or Anja, I can add. So yes, so indeed, many times when we say we are a pediatric foundation, we really focus on more beyond pediatrics. So we focus on families, adults, adolescents. So yes, we have services for children who age out. And one of the things we do quite a lot in our programs is support for transition. So as you know, as children get to 10, 19, 20, 24, they transition into adolescence and into adulthood. And so we have a lot of support to support them to transition out of pediatric services, to transition then out of adolescent services into adult services. And one of the things we support is self-care and self-management, so that when they are in the adult space, they're able to manage their diseases as much as possible. Perhaps Apollo or Anja, you want to add to that?
Actually, I wanted to follow up with another question to Apollo, because you talked a bit about COVID and the impacts of COVID. There's a question about what the foundation is doing to advocate or try to get COVID vaccines for children with HIV. You mentioned other vaccines, but if you could talk about COVID vaccines. And there's another question about how were you mentioned the COVID challenges for children. Are they fundamentally different than the challenges for adult treatment? And if so, how is another question.
Thank you very much, Kathleen, and thank you, the audience, for the question. I will start with where Judith stopped before transitioning to the question related to COVID. Just to remind everyone that in terms of public health structure for pediatrics, we have age categories. We have 0 to 4, 5 to 9, 10 to 14, 15 to 19, and 20 to 24. And we certainly have data currently and systems, the DHIS2, that the countries can actually put in data, and we can see, we can monitor the transition between various age categories to, and monitor through the progression on, of the epidemic between the various age bands, because also the intervention that we put in place are related to the age band. A 0 to 4, sometimes behave slightly different from the 5 to 9, and the 10 to 14 will behave totally different from late adolescent, 15 to 19. So I just wanted to add that perspective, and we certainly have studies where we are tracking some of these changes currently. And so quickly moving to the vaccines. Currently, I mean, the numbers I'm giving is common knowledge to everyone that the coverage of vaccine in Africa is less than 3%. That those who are currently eligible. The eligibility in Africa is 18.
What is it? I'm busy.
The eligibility in Africa currently is 18 years and above, and that the coverage for that age group is less, like I said, is less than 3%. And in some countries, it's as low as less than 1%. So it is a little bit tricky right now, and there's a lot of vaccine hesitancy. So currently, from the public health perspective, we're designing communication, where to basically mobilize communities to understand the safety of the vaccine, because the parents, if the parents cannot take, believe me, they will not want their children to take it. So if there's that much hesitancy, it's important to build trust of the communities around the vaccines. And that is what most programs are currently doing. And we are hopeful that soon things will move in the right direction. So that being said, when it's important to remind people that as an organization, we support national policies. When we get to a country, we also support national policies. And once countries we're supporting have shifted the age band, certainly we'll provide the necessary technical assistance and support to see how things can move in that direction. So, and based on the WHO guidelines and based on the various country policies. Now, talking about the impact of COVID, is it different from that of adults? We know children depend on their caregivers, certainly. So, and COVID, in terms of health systems, when the facilities are closed, if the caregivers cannot take the child to the facility, certainly, that secondary dependence, suddenly the child is more affected. And adults generally will want to be sure that things are safe out there before they allow the children to go out. And the early phase of the COVID, where there was school closures and other interventions, definitely the children were much more affected than usual. And the last point, which I will link it back to what Judith said, in terms of transmission, 90% of the pediatric HIV is from mother to child transmission. So if the facilities are closed and the mothers are not accessing the facilities for their care, for the maternal and child health care, certainly the unborn child is at risk of acquiring the HIV, whether in utero or perinatally or through breastfeeding, as long as the mother has missed those opportunities. And lastly, children die quicker. So if these children are infected, as we have had COVID now for almost 2 years, and you remember the data from Anja that shows that by the second birthday, 50% of those children will have died. So if you measure this impact, like in 2-3 years' time, you may think that there was not much impact, but obviously because those children are dead. The children who were infected 2 years down the line, they are gone. 50% of them are gone. So when you measure the impact at that time of transmission, what you are measuring is only 50% of them who have been resilient and survived. So I know I'm mentioning so many numbers here, but that is the way children are more vulnerable. I think in summary, children are more vulnerable, and in the pandemic, with this unseen enemy of COVID, they are even much more vulnerable. And with COVID, with HIV, it is even more difficult for us to have visibility on what's going on. Thank you.
Thanks, Apollo. That's very clear. There is a question for you, Judith, about you put a lot of emphasis on community engagement around ending pediatric AIDS. There's a question about, do you have any examples of the kinds of interventions that can increase this community engagement in the way that would be most helpful?
Thank you. Yes. So when I look at the various areas from case finding, treatment optimization, and viral load suppression in terms of community engagement, indeed, we have a lot of interventions. So one of the things around community engagement would be in testing. So working with communities to identify areas, or to go to the homes or the communities where we have pregnant women who are untested, to test them, to prevent mother-to-child transmission, or use the community resource persons to reach to homes where we have children perhaps who are not tested, to improve the targeted testing. So that is, working with the communities around testing. And now when you're doing index testing, we work with community health workers and lay persons to do this testing. When it comes to the area around treatment optimization, indeed, one of the community resource persons are the caregivers, who we can work with, and we have worked with them in our projects to develop materials to support them, to train them to be able to give children medication and bring them back to the clinics. Remember, the children from 10 and below rely a lot on their caregiver. So for us to be successful, we really must work with the caregivers. The community has a lot of work in terms of monitoring the services, offering psychosocial support, adopting community-based the differentiated treating and testing models, so that a lot of the work that is being done in the community is safely in the facility, is safely taken to the community under the watch of the community resource persons. So there's a lot that the community can do. The community can also be used to address certain myths. So one of the things we've done at the foundation is work with our adolescents, and we have a community group of adolescents called youth advisors, and they have worked to develop certain myth busters based on what is being said out there to address certain myths around COVID. So the community can also be a good tool to use to address certain myths and to address certain changes, and also to give feedback to the facility on how services are being taken out there. Thank you.
Good. Thank you.
Kathleen,
Yes,
Kathleen,
Anja.
one more addition to how children were differently affected than adults during the COVID situation is that the quantities of ARVs for children obviously are much smaller in countries, so there is much less bandwidth of taking in challenges. And what we've seen is that quite in a number of countries, the pediatric formulations were at very low stocks or even stockouts. And so there was a lot of changing of regimens, and that's never good for switching, obviously. Also, it was just a time, I think Apollo mentioned it, where we were introducing more child-friendly formulations, also better formulations. And that was severely hampered because of logistical issues. And so I think that just because it's a smaller volume, really the drug supplies for children and even the cartridges for early infant diagnosis were much more affected than for adults.
Good, thanks. An important point. Another issue.
So Kathleen, sorry to interrupt. I wanted to mention one more area around the effect of children on COVID. As you can see, it's a topic that we are passionate about. Remember when COVID hit, a lot of the countries closed the schools. And so there has been an impact on that in terms of the learning implications. There's low rate of returning to school. We have seen a lot of cases of gender-based violence, teenage pregnancies, HIV, and child marriage. So that also is an element that has impacted children around COVID. Thank you.
Right. On the same theme, have there been evaluations, or are there ongoing evaluations on virtual services versus the in-person services? Because I guess some people would say, well, adolescents in particular really function around text messages and WhatsApp messages. I mean, has there been any upside to the virtual services, or is it just a net loss in terms of the effectiveness and outreach?
So there has been some evaluations, and that's a very interesting topic. And at EGPAF, we are looking at the data, and we are going to be continuing. But looking at data that has been shared by PEPFAR, who is the funding for HIV from the US government, they looked at viral load testing coverage and viral load suppression. And viral load suppression improved among adolescents as compared to children. And they think it's because for the adolescents, they adapted more to the virtual space. So some of them were doing virtual, virtual enhanced adherence counseling, virtual follow-up. So it was much better for the adolescents, unlike for the children who rely on caregivers, and perhaps the caregivers are not really adapting quickly to the virtual space. So that has been reported by PEPFAR, and it has shown that difference. But I think by and large, there's not much of additional evaluations, but that would be an interesting topic to look at. The other thing we have looked at EGPAF is our programs that adopted the virtual pediatric case management, program that adopted virtual trainings, and now we are looking to see, the effect of those trainings, because a lot of them were done virtually, and are being adopted as a way forward on doing subsequent capacity strengthening approaches.
Thank you. That's very interesting.
Yeah, just to add that at EGPAF, certainly from the health system perspective, we have introduced quite a number of virtual approaches, especially in providing technical assistance. And I mean, one of them, which is a DISC, DISC, and certainly we are working with the team that is, supporting countries to use that tool for technical assistance to see what would be the impact in terms of quality of services, moving things forward. Lastly, the ECHO training, using ECHO platform for trainings and across countries has increased, and that was certainly to support healthcare workers, who needed more training and capacity building. The one key thing during this season that made things quite complex is that this was the time we were introducing a new treatment, the pediatric dolutegravir, DTG. I don't know whether I'm going too much into detail here, but it was during this time we were doing program optimization, and certainly virtual interventions were important to really ensure that we support healthcare workers, and certainly give opportunity to children and adolescents to ask questions through WhatsApp groups. On the continent, there are certainly a number of WhatsApp groups where young people can chat and then ask the right questions. And we have seen some stability there. That being said, we know that those who thrive well, they are the resilient. And public health, intervention is really for those there's sometimes that will have missed, and those are the people who are suffering from the negative impact of the COVID, and whom we need to reach out to and help to all be around the table. Thank you.
Thank you. I think we've covered most of the questions, so I just want to make a few summary statements and then ask each of our presenters from EGPAF to give one takeaway message. I think we've been clear during the webinar that pediatric AIDS, 90% of which is due to mother to child transition, is actually within reach to be eliminated if we use all the tools that are at our disposal, and if it's given adequate political attention and financial resources and support through the health system. I think that's an extremely important message for our listeners to take away. That great progress has been made both in reducing the cases of pediatric AIDS, but also in tailoring treatments and programs for children, and in following those children through adolescence into adulthood. That COVID is having devastating and ongoing effects on this progress. And while COVID is affecting everything, I think we've highlighted some of the very special ways in which it's impacting on the progress that is ongoing related to pediatric AIDS. That being said, that EGPAF and partners are actively coming up with ways and developing ways to try to mitigate these impacts. And actually, I think one of the challenges which we haven't talked about that much so far, but might come up in your last messages, is trying to take the attention that COVID is getting and perhaps the increased resources that COVID is getting to actually strengthen other services for children, including those to eliminate and to respond to pediatric AIDS. So those are just a few, I think, of the important points that came through, but I will end by just asking first Apollo, then Judith, then Anja to give one takeaway message. Apollo.
No, thank you very much, Kathleen. I think in one sentence, we should remember that COVID and HIV is double trouble for children who are disproportionately affected or impacted by both diseases because they are usually neglected in public health. There's need to adapt our programs to turn around the tide to, to bring us on track to end pediatric AIDS. Thank you, everyone.
Thank you. Judith.
Thanks, Apollo. I think apart from the fact that what Apollo has mentioned around programmatic resilience, adaptability, I think just to say that the community really must be at the heart of the response, be it HIV, COVID integration. We can't really run away from it. Community leadership, creating political will to create actions that really affect the elimination agenda. So I think that would be my one take-home message.
Thank you, Judith. Anja.
Yeah, most have been said by the three of you. That's the disadvantage of going last. But I think to repeat what you've said, Kathleen, we have the science, we have the tools. There is no excuse for not doing it. But we do need to make sure that we do have political will at the global level, at the country levels, because I think for a while there was this sense of where we're getting there, we can relax now. And I think we've seen from the data today that that's not the case. In fact, we're reversing on our gains. And so we do need to start putting our straps on again and really focus on this issue, even though there is COVID distracting us, because we are losing the gains that we had and we'll have to start all over again. So focus and political will is needed.
Thank you, Anja. I think that's a really important last message, because I know we have a lot of public health practitioners listening in to the webinar. And in this case, as in so many other cases, it's not enough to have the technical solution. You also need to have the political solution to a problem. And that's a really important piece in this puzzle of eliminating pediatric AIDS. So I really want to thank everyone. Thank you for joining. Thank you very much to Anja, Judith, and Apollo, and to the Dean for making this webinar possible. And we hope this has given food for thought on an extremely important global health problem of our time.
Just adding my thank yous as well to all of you from the CUNY Graduate School of Public Health and Health Policy. And we know that your challenges are great, but we also know that you're up to these challenges. This was most illuminating and a very interesting presentation. On behalf of my faculty and my students, I'd like to express my congratulations and my gratitude. Thank you so much.
Thank you.
Thank you.
Thank you too for having us.
Thank you.
Thank you for having us. Thanks.
Bye-bye.